Tonight, it's not exactly Mighty Mouse, but we'll get into that in a minute. And I've just got to get this done. There we go. Everything working. Welcome to this week's weekly weha.com roundtable. I'm John Lyons. John, joined as always by the managing editor of weha.com, Ronnie Newton. This week, we're going to be talking everything vaccine related. We have two incredibly well-qualified guests who are going to talk about what is expected to be tomorrow's FDA emergency use authorization of a vaccine to combat the coronavirus known as COVID-19. First, we welcome Keith Grant. Keith is the Senior System Director for Infection Prevention at Hartford Healthcare. And Keith also serves on Governor Lamont's COVID task force and is a trusted advisor to Governor Ned Lamont. Keith will tell us about the vaccine rollout in Connecticut and when you can expect to be able to get your vaccine. Later, we're going to have one of our regular guests back on, Dr. Nicholas Bennett. Dr. Bennett is an infectious disease expert and an expert in vaccine development and testing. Dr. Bennett will tell us about the science behind the vaccine developments, as well as what goes into the development of these vaccines and how safe they are. So we're going to really try to cover everything. And Ronnie, I'm getting an alert here. It looks like something happened on WeHa, the Facebook page. Can you confirm we are live on that page? Because I don't think we are.
We are live on that page.
100%? Because I've got a note here that we're not.
I see it live on the page.
Okay. All right. That's very weird. I got an alert. Okay. Well, we keep rolling as long as we're good on YouTube and TV and hopefully WeHa. So, all right. Keith, welcome to the show. Thank you for coming on.
Absolutely. Thanks for having me.
So you got a lot of balls in the air between your real job, and serving on the task force, and then you do a lot of media appearances. In fact, if viewers want to click on the link to the right after the show, I've put a post in here. I put the link to your news conference earlier today, where you kind of gave a state of the state in terms of where we stand in terms of COVID and where we stand in terms of the vaccines. So Keith, where do you want to start? You want to talk about the numbers, where these high numbers are coming from, or do you want to jump right into vaccines?
Yeah. So also a huge part of my role is I'm still with the military. So I'm still with the reserve, which is one of my favorite things to do. So,
well, I didn't know that. I apologize, but thank you.
Yeah.
Which branch are you in?
Air Force.
Okay, terrific. Do you fly? Do you get to fly?
Oh, not anymore. So I was a part of an air crew, medical air crew. So air medical evacuation for 8 years. Eight great years. My wife would say otherwise. A lot of work.
Probably 8 nerve-wracking years would be the word.
Oh, absolutely. Some good stories.
So I'm sure. Well, you know what? Now we have an excuse to have you back on, because we can talk military. So we'll definitely get you back on for that. So and thank you for the service. So let's talk about the numbers in Connecticut and across the country. I mean, this summer, there's no. I think by any objective view, Governor Lamont's done a really, really good job. But even doing a really, really good job, the numbers have gone bananas over the last 90 days. We were averaging under 100 new cases a day in early August, and we're now averaging somewhere between 200 and 2,500 new cases per day. Hospitalizations are up. Sadly, deaths are trailing, just like they do in this disease. Hospitalizations trail by 2 weeks, and deaths trail another 2 or 3 weeks after that. Where are these cases coming from?
That's a good question. So if you look at a number of communications and news briefings, not just from myself, from Yale, across the country, we identified certain events that would increase these numbers. So one of the things that we identified is the upcoming holiday season. How this virus works, and a lot of times, and if you guys have seen me talk about this before, strip away all the science from it and just look at what it's been doing in its most basic form. So it needs group settings in order for it to move forward. So an identified source is not a true vector if there's really no one for that person to pass it on to. And an identified source, again, if it's their source control, we're really not worried about much. So I think a lot of what we're seeing is, as predicted, is coming from the holiday season. However, another thing that happened, right, when you look at the Connecticut data and how the data shift, there's a time that there was a sense of anxiety, a significant sense of fear that's around this virus, and a lot of people had lost loved ones. So the mortality rate has shifted. So less people are dying from this disease process, right? The visceral effect of someone dying is I don't want to say it's gone, but it's not there as much. The other thing is there's a lot of people who are just fatigued about this whole process. So less people you see are wearing or doing the appropriate things, wearing masks. More people are questioning how necessary this is. And a lot of people are, a few people are challenged by the notion that I might have been positive before, and so I might have had I now have antibody, and hence I don't need to do certain things. So there's a multifaceted way to look at this, and I don't think it's one singular thing that's contributing to this, but I do believe that we've, as a state, we've done the right thing before to get us to a very reasonable, very low number. And I'm very confident that we're going to get back there.
Well, I think we also look at Connecticut and we think things are pretty grave here now, but compared to so many other parts of the country, it's really a whole lot better here. And I see, newscasts from other parts of the country or posts from friends on Facebook, and people are wearing masks in Connecticut so much more than they are pretty much anywhere else.
But one of the things too, though, right? So you reached out, for example, multiple people have reached out and said, hey, Hartford Healthcare and your team, how can you come forward to this community and educate them? You have to first believe in this whole concept, the science behind it, in order to do that first, right? So there's good parts of the country that just doesn't believe in the basic science of it. So they're not gonna pass this information on as much as possible. And I think that's one of the missing things. Connecticut, I think, has done a very, very good job. Hartford Healthcare, we've done over 200 media briefs. We have the call center we set up very early because we do believe like platforms like this and spreading the message is going to be the primary means of actually curbing this thing. One of the primary means.
I do. It's I'm not a scientist. I'm not a doctor. I've got no medical training whatsoever. But I like to think that I'm smart enough to listen to the scientists. I'm also smart enough to understand that science is not exact. It's not necessarily binary like computing is. And so we've got this whole segment of the population who, maybe are listening to sources, people that are not scientists, and maybe have other agendas, another agenda that might not quite be, the health and safety of the citizens. And, how do we convince, 30 or 40% of the population? I know the number's lower in Connecticut, according to polling, but thankfully, how do we convince a large segment of the population that, look, these vaccines are safe and efficacious, which is a fancy, SAT word that we've all learned in the last 6 months. So maybe not you, but, a lot of people.
I mean, there's people in the medical community.
You already knew it, I'm assuming. I'm sorry. I should clarify that. You've known it for years.
Hey, journalists know big words too.
Exactly.
There's a lot of things in the medical that is new about this in the medical community as well. There's so many people who, a lot of our colleagues that are getting asking for the same exact information that many people outside of the medical community is asking for. About with the safety of the vaccine. So the communication that I've been having, or the conversations that I've been having, is very focused on the fact that I think people are challenged by this is new. So this is new, and it took eight months to put this together. A normal process would take significantly longer. What I keep pointing out is the fact that this technology is not new. So the technology has been around for a good while. I think the first time the technology was used in 2004.
The mRNA technology?
Yeah, mRNA. What do you mean? Define for us what the technology is.
Good, very good. So the most basic way to look at it, right? So creating a structure wearing, what I would be able to do, I need to communicate with the cell. And in communicating with the cell, I'm going to basically say, I need you to go and get your defensive guys. Dr. Troy put it very well when he said, you're basically getting the National Guards prepared. So I'm getting you trained for a specific mission. In this case, the mission is going to be to, when the SARS-CoV-2 virus enters your system, you have the appropriate systems in place in order to fight it. That's basically what it is. So they created a vehicle that carries the message to the cells and say, this is what you need to start doing. That technology, the mRNA, so the M part of the whole process, that technology has been available. Now, what we've done is identified this opportunity with the SARS-CoV-2 virus, and we said, you know what? The specific protein from the SARS-CoV-2 virus, we're going to use that, send a message through the mRNA process to the cell and say, listen, start developing this and prepare this person for battle just should in case this invasive process come in and start taking care of it. The hope is this work, and when you look at the data that's coming out, the effectiveness of this, or how the efficacy of it, 95%. So if you look at your normal flu vaccine, a good performing flu vaccine from an epidemiologic perspective, 60%. So if I have a 60% year with the flu vaccine, I think most ID infectious diseases providers, most infection preventionists and epidemiologists will be very, very okay with that. A bad year for the flu vaccine is, 20, 35%. The average year, lower year, is about 45%. So we have a vaccine that is 95% effective right now with a technology that is not it's not just a new technology, right? It's technology that has some research behind it. The messaging that goes in within the technology that complements this process is new. And it's new because this is a novel virus, right? So those are some of the key things that I think people should focus on. The hope is as well, when you look at this technology, the next time we have any form of pandemic, it's really easy to appreciate this actual technology itself. Use this new virus, this next new virus, or next new whatever comes up for a pandemic, and we send a message and again get your body prepared for this. And we're hoping that will happen within the next few years. But
now, why can't this be used for the regular flu? Is there something different?
Even the common cold.
So I will say on this show that I imagine that's going to happen.
Was that a yes to both of our questions?
Absolutely.
Because that's what struck me. My very basic ability to understand the research behind this. That hey, these guys inside of a year have found a cure for the common cold, or at least a pathway to the cure for the common cold. Yeah.
So the thing with the common cold is, right? So remember, the common cold it's called the common cold because it could be so much other things.
Yes.
So I have the cold could mean everything and a lot of other things, right? So what we do know at this point in time, when we identify it as flu season, it's one of the many respiratory viruses that are floating around and cause what we, rhinovirus and such, cause what we call the common cold. The ones that obviously will cause the highest loss work, the highest mortality, like influenza, for example. I see, and a lot of people within the scientific community is looking, is this an opportunity for us to restructure how the flu vaccine is and administered? But as it stands right now, and looking at the structure and the efficacy of the COVID-19 vaccine, I think we should only be impressed. And then keep in mind, when the FDA looked at this, and the FDA sanctioned, or Pfizer and Moderna, for example, came forward and said, we're going to develop a vaccine. The FDA said that in order for us to clear this, from the statement they made, you're looking for at least 50%. So we had appreciate as a general scientific community that 50% would be good. We're at 97% at this, or 95% at this point on average.
So I heard you talk today. I'm sorry, John.
No, go ahead, Ronnie.
Okay. About how this vaccine can crush the curve. How even the first dose will be effective, and with both, it'll just really crush the curve.
Yep.
But I read something else in the New York Times yesterday or the day before about the vaccine possibly being just like trying to spray a fire hose on a forest fire. Can you kind of talk about how both of those things can be true?
Well, I think that's a very, very good question. So if you combine the concept of, if you look at just the vaccine and what it's done, so we spoke about the efficacy. The vaccine isn't effective sitting on a shelf. So we produce 20 million, 40 million vaccine, and it's not being accepted by the community. We just have vaccine. We have a really good scientific project. It's a very good science project. That's all it is. If you look at the percentage of people who are looking at taking the vaccine, as it stands right now, we still need to get to what I would consider, and I think what a lot of the communities are considering, more of a herd immunity for us to really appreciate this. And if we're not, if we don't get to that point, I agree. It's not the big bang that we're hoping it will be. But if this is administered and distributed logistically, if we find the best way to administer and distribute this the right way, this is a game changer by any means. It's a game changer.
Okay, so there's a great opportunity to talk about the logistics, because I've read articles as well. There's a lot of fear over the lack of preparedness nationally, logistically. That the people in government, and I'm not getting political here. They simply don't have the supply line and supply chain rather management understanding and logistics management to be able to handle this. Is Connecticut? Let's just talk about Connecticut right now, but I know it probably mirrors the rest of the country. And we actually have somebody watching in England right now. But so we've got people all across the area watching. And are we prepared logistically to provide as many doses of this as we need to get our citizens vaccinated?
So I think Governor Lamont and the team that he's put together, led by Dr. Reggie Eady, and the health systems throughout Connecticut, to include Yale and Hartford Healthcare and Trinity, I think they're very well placed to ensure that the citizens in Connecticut are vaccinated as soon as we do have the vaccines. The logistics about getting the vaccines to us. So I think the military, so my understanding is federal government, working with the military and the logistic team, which I do believe is one of the best in the world, is manning that at this point in time. So I do have confidence that will happen. But again, it goes back to messaging. Like, if people are not comfortable with the message around the actual vaccine, if it continues to be very, very politicized, which I think that's the challenging piece of it.
Yeah.
It doesn't make a difference. There's no science on masks. Like, I've said that so many times. It's a basic concept. There's something coming out of my respiratory system that's potentially infectious, and I'm going to block it. That's it. It's simple. There's no science.
That to me is binary. I couldn't agree more.
There's nothing else to it. The vaccine is the same thing, right? So there's something that will give you if I have a grandmother, which I do have, that obviously with increase the advanced age, she's 88, it's the advanced age. Nothing else, that's going on. But just the fact that she's advanced age, if she do get the COVID, their potential for mortality is higher. So I have something that will give 95 to 97% chance of her surviving this virus. I think it's hard for me. It's very hard for me to debate against that.
And we're going to be talking about morbidity and the age versus in various age groups. We're going to be talking about that in the second segment. So we actually have a slide on that the doctor sent us. So Keith, could I trouble you? I'm going to put up this distribution plan. We're still going to be able to hear you, but all three of us are going to disappear off screen here for a moment. I'm going to show this. And, could you talk to us? Now, this is, I know it's probably a little bit of a living document. I get it. But could you talk a little bit about what the game plan is? And mics are still on, Ronnie. Sorry about that. But we've got a vaccine distribution plan. Could you talk a little bit about that?
And again, this is coming from Governor Lamont's team, Dr. Reggie Egypt leading this initiative. So phase one are healthcare workers and nursing home residents. It's a nursing home residents actually moved into the phase one versus the phase B, primarily because the increase in mortality, especially over the last few months, last few days, that we've seen an increase in rates in nursing homes. So it's moved over. That process actually created a reallocation of a vaccine from the healthcare workers during nursing homes in the initial rollout. So, nursing homes, our healthcare workers will see, a slight shift in the amount they would get. Medical first responder, first responder, medical first responder, or EMTs, I always like to just put them up with our healthcare workers because we're working so close together. And I think their risk in emergency room docs are very, very high. Critical workers, so phase 1B, so January to late May. Going back to phase one, so by December 13, 14, we should start seeing vaccines within the healthcare system. We should have hands-on vaccines to start distributing and administering to healthcare workers. And then once you move from 1B, you're going to look at your vulnerable population. Age is still one of the very high risk. So adult over 65 and high risk group over 65. So your people that have, chronic respiratory diseases, diabetes, and so forth. And congregate settings. So congregate settings such as prisons, obviously we've seen significant numbers in those areas. So hence we want to make sure those guys get vaccinated as soon as possible. Phase 2, so under 18 and remaining over 18. So that's the phase 2 is in like June, so to speak. So we're hoping, the big push when you look at this, and I just went for my mouse to try to move this, but anyway, so the big push when you look at this is like very, very simple logics, right? So the people who are highest risk right now, your forward facing healthcare workers. And if you stratify that even more, you're looking at like your critical care groups, you're looking at your ED providers, include your nurses and your physician, your custodial workers in the ED, everyone in the ED, your first responder. And if you look at why that risk is so high, right? So in the emergency department, you're seeing patients that you have no idea what their statuses are. So I don't know if you're positive, you haven't been tested yet, you haven't been triaged, or there's nothing about you that we know that we can rule you out for COVID. Your first responder is the same thing. So nursing home, we spoke about already. And then everything else. So if you just strip the science out of it, and we had a discussion of who do you think should get this vaccine, I think most people can agree this is a good plan.
Okay, so question for you, and we'll come back to this. So I'm looking phase 1A, December 14th. Now, Ronnie's daughter is a healthcare worker. My wife is a healthcare worker. Where would they go? Now, I think Katie did sign up. I know Jessica signed up. Where would they go, or are they going to get an email telling them how to get their vaccine?
Good. It's a good question. So I can tell you, if you're a part of the Hartford healthcare system, you will get communication from the team that states that you've been identified to get the vaccine at this particular point in time, and go online and set up an appointment, and we'll ensure that the vaccine gets to you. Keep in mind, 2 dosage we're also coordinating that to ensure that people are getting the second dosage at the appropriate period of time. But entities, the Hartford Healthcare, Yale, Trinity Health, a number of the healthcare systems across the state are going to be, setting up their administration and distribution to include communication to the individuals that need to be vaccinated.
Okay, so Hartford Health, but somebody who's not part of the Hartford Healthcare Network or an employee, like I said, let's talk about Ronnie's daughter who's in healthcare, not affiliated. Would she go to a CVS to get her?
She wouldn't be going to a CVS. There would be an affiliation with whatever. Generally, there's going to be affiliations with whatever entity that she's a part of. With like the Trinities, Yale, Hartford Healthcare will partner with that. Most healthcare institution does have a partnership with one of the bigger health systems, and hence that's how they're going to get it. But CVS and Walgreens are going to be partnering through a federal program to vaccinate the nursing home residents.
Okay, so that's what they're initially going to be doing, going out to the nursing homes.
Absolutely.
And delivering the vaccine that way.
That's correct.
What about the EMTs? Will they, West Hartford Fire Department, for example?
Good. So West Hartford Fire Department, for example, let's say they're affiliated with Trinity Health of New England, they will be Trinity Health will take that responsibility to administer to them.
So they'll be told, right? They'll know
absolutely.
what.
Yeah, absolutely.
Okay, what is the definition of a critical workforce? We have that question with several follow-ups to that question.
Teachers, for example.
There we go. They were looking for that.
How about journalists?
Yeah, of course.
I've heard that we're actually on the list because we need to go out and report on things, whether it's kind of dangerous or not.
Like, people don't appreciate like how, and I've said this so many times. So Tina, Rebecca, Nick from our team, how important they have been for us. Like the thing that we had, so it wasn't medicine, right? So the people that I've looked at as heroes in this whole thing, so it wasn't medicine, because medical treatment that in the beginning of this, we weren't too sure how we're treating this. Like there's many times it was so humbling. There's so many times that I can actually say I have no idea. And the things that we had is, we know there's information that was constantly coming out. There was misinformation. So we had to fix that. So we had to fix that for our community. Tina, Rebecca, Nick, ensure that we had that process, working with teams such as you guys and Fox 61 and news, so many of the news channels. So the media was so important. The other thing is our custodial staff. Like, we know for a fact that by keeping the area clean or keeping the place clean, we have a better chance. So these are the groups, so our nurses or physicians or doctors, we relied on less conventional means for fighting this in the beginning. So true heroes in this include you guys.
I mean, I know this is highly speculative, but do you think, and then we do have a few more questions for you, but do you think people are going to be, do you think there's going to be more supply or more demand in January?
For the vaccine.
Phase 1B.
For phase 1B.
Yeah.
Phase 1B will have more. I think that's a hard question.
Yeah.
So phase 1B, I think phase 1B should be appropriately facilitated. I think enough vaccine should be available for phase 1B. I think phase 1B is going to have high level of demand though. So, when I spoke about before the visceral effect and visceral impact, there's a lot of these adults over 65 that's probably lost a friend or someone very close to them. And knowing that if this was a process that was available before their friend got infected, their colleague, someone they've been friends with for years probably, if this was available, it would have saved their life. They're probably going to be hands up to go get this. I think a lot of people in this group is going to be getting. Critical care workers are always high self-sacrifice. Your teachers and stuff will ensure that they get it. I think the demand, and at that point, I'm hoping Moderna, Pfizer, and if anyone else come on board to get an EUA at that point, will be stocking the supply group of it. But I believe it should be interesting. I think that's a very, very good question. But I think it should be fine. It should meet just economics on it should be good.
Is your task force going to stratify who within 1B gets it first of that group, or is it first one to fill out the form gets in line first?
No, I think it's going to be more stratified. There is a lot of work. Its task force, I believe, is meeting on Monday. There's a lot of work that's going to be done in that meeting, and I believe it's going to be more stratification that's done on that.
We do have a question, which might be, I don't know if it's more appropriate for you or for Dr. Bennett, but we could ask both of you, but I'll start with you, is will people have the ability to choose the Moderna and Pfizer vaccine? And my understanding is they're really basically identical, but what are your thoughts on that?
They're basically identical vaccines. And if you look at like what we'll get first, for example, Pfizer obviously is along the process much more than Moderna. So for healthcare, for our 1A colleagues, people who will take the vaccine yesterday, if it was available, they're obviously going to be getting the Pfizer vaccine.
Okay.
I think it's the same technology, so the mRNA technology, and with very close, very similar efficacy. So I think it should be fine. I can't imagine most people who would say they need to get the vaccine right now is going to choose between both.
All right.
But what I've read also is that it's critically important that if you get one of them first, you have to get your second dose of that same brand
Absolutely.
vaccine.
Yep, no mixing.
Yep, got you there. I know that came up in the press conference today too. So, all right, Keith, any parting shots as we try to respect your time? We kept you to 31 minutes anyway. Any parting shots? And I am going to, put you on the spot. We're going to invite you back on here, maybe early January as this rollout continues, so you can continue to give us updates, because I think this stuff's so important, and I can't emphasize enough your words. Right now, it's a matter of building the public trust. I think that's so vital. So any parting shots before we say goodnight?
So there's a lot of information that's out there now. Get informed. That's the first thing. And
is there a website, Keith, like even state level? Any recommendation there? I can put that in the chat.
State documents. I think there's going to be a more updated document for the state very soon. The CDC has some very good documents. FDA just released some documents. I can send you some stuff too if you send me your email, so you can share with the folks. The FDA release, the summary and release that was done yesterday was probably the best document we've received so far, most in depth. But the key thing I would say is get informed as much as possible. So if you make this decision not to get it, you're able to, it's not political. It's nothing but I've read something within this document that was produced by the FDA and I'm not okay with it. And that's fine. And I would be happy to have that discussion with anyone.
And we are going to talk a little bit about, I know in some cases, allergies will impact whether you're able to take. So there are some legitimate reasons, but, trusting one news source or non-scientific sources is probably not the best way to base your decision.
Absolutely. And the other thing that I would say is this is a novel virus. This is a novel virus. And one of the things that we have to appreciate as what we've done over the last few months is a testament to what we've achieved over the last 100 or 150 years. This is 10, 20 years ago, we wouldn't have had this capability. From a science
Yeah.
perspective, we would not have this
And
capability.
the fact that it looks like, and we're going to talk a lot about this with Dr. Bennett too, but the fact that there's no question you can recatch this, it would have been devastating had this happened 20 years ago. I mean, I've had it. I wouldn't wish it on my worst enemy. I recovered about 2.5 weeks ago from it, and it was awful. I couldn't walk up a flight of stairs. So everything you hear, from the scientists, from Fauci, his team, is, in my book, dead on accurate.
Absolutely. So that's my thing that I constantly say: get informed, and if you feel like you're there, feel free to pass information on. So
I want to know who gets it first in Connecticut. Who's going to be the very first person to get that?
Number one.
I'm struggling with this, and I'll tell you why. So from the perspective that people are wondering about the safety of it, it should be like a high tier leader, right? So someone goes forward and be like, listen, guys, it's safe, I'm taking it. But from the perspective that the people who really need it are your vulnerable population and your 1As or your healthcare providers, it should be someone that are probably a critical care physician or a critical care nurse per se. So that I think both probably, two people are doing it, but it needs to be someone that you can, there obviously need to be a trust message within the first person to get it.
But I heard that patient number 2 or the person number 2 in the UK was named William Shakespeare.
There we go.
So.
Nice.
You couldn't have picked somebody better in my book.
Yeah.
So
that's awesome.
Awesome. I'll wrap it up with this. I saw a funny post on Twitter today where somebody, and I wish I remembered who it was, but they basically said, I wonder what Bill Gates is doing now that he knows how to track a 90-year-old woman in Wales, and I thought that was so funny because it's so clearly laid out that some of these nonsense conspiracy theories that we're hearing and just debunked it in one sentence. So anyway, Keith, thank you so much. We really appreciate your time, and we definitely would love to have you back if you're available.
Absolutely, man. Anytime to pass the message on, I'm willing to be on.
Thank you. Thank you so much.
Thank you so much. We really appreciate it.
Bye, guys.
Take care. All righty. And now we're going to welcome in one of our usual guests. We got the countdown happening. Nick Bennett. Ronnie, bear with me. I'm going to try to swap you guys here for a second. Okay. Nick, how are you?
Hello. Can you hear me?
Yes, I hear you loud and clear. Can you hear us?
Yes. No problem.
Hey, Nick.
I actually have a proper introduction. Rather than just calling you Nick, I'm going to give you a proper introduction. Dr. Bennett is an infectious disease expert, and he's an expert in vaccine development and testing. And we're going to be talking about the science. We talked a little bit about logistics. We did go into the science bit a little bit, which I think is good because I think the messaging is really important. But we're going to talk a lot more about scientists and what goes into the development of these vaccines and what's in them. I've got some anti-vax folks that I know that are telling horrible stories about aluminum and I don't even know what else being in these vaccines. And so let me start with that question because I know and we have a lot to cover. What are the ingredients of these vaccines?
Well, it really depends on the vaccine. The Pfizer one, actually, which is the one that's hit the headlines recently because it's the most, not necessarily advanced technologically wise, but most advanced in the approval process.
Right.
They very clearly laid out what the ingredients are on the FDA submission. So they're right there in black and white, and they're actually surprisingly simple. They're mostly collections of lipids, fats, which form these little nanoparticles, so the liposomal nanoparticles or LPNs, which hold the mRNA inside. So they don't have a viral component except for the genetic mRNA. And they make a little artificial particle basically out of lipids. And they list the lipids. There's several of them that are there. So they're all, including cholesterol, but they're all normal things that you'd expect to see in a cellular or viral membrane, because they want to mimic that kind of approach. And that's to stabilize the molecule, because mRNA it falls apart so easily. It's extremely fragile. But it's the best way to make this kind of vaccine work in a safe way. And so the best way to keep it solid and keep it stable is with this lipid nanoparticle. So they're basically fats. There's sucrose, which is a form of sugar, and there's a collection of different salts, some of which are literally just sodium chloride, and then there's various potassium salts that are in there in small quantities, and that's it. There is no preservative, there is no adjuvant, there's nothing funky in the vaccine. It's actually surprisingly simple, and that's probably aided its development in terms of, I mean, we talk about this being a new vaccine, but actually the technology has been researched for about 10 years in different forms and with different diseases in mind. And so this very rapid development and deployment of the COVID-19 vaccine is built on a decade of research in the lab and in animals and in people, and then they've just pivoted. Instead of looking at other viruses, they ramped it up and pivoted right into COVID. So the technology is actually very clever, but also surprisingly simple in how it's been put together. And I think that's helped in terms of production and the experimentation they've had to do to get here. So for the Pfizer vaccine itself, it's basically fat, sugars, and salt, and that's it. So it's basically a bad diet. And the mRNA.
So I'm gonna drill down a little bit, because things I've seen on Facebook and things I've had people ask me, and including in advance of this show, wanting the answer, and they're watching now. There's no aluminum, which I don't even know. I mean, we use aluminum in everything, but there's no aluminum.
Yeah, aluminum is used in some vaccines as an adjuvant, and what that means is it stimulates the immune system, so you get to use less vaccine. And so it's actually a good thing to have in there, because you don't need as much of the vaccine in the body to get the same immune response. Now, if you took the aluminum out, you'd have to immunize people with a lot more proteins or virus or whatever you're using to get the same immune response. And the amount of aluminum that's in a vaccine is incredibly small. And really the best example of this is looking at the childhood infant vaccine series. If you add up all the aluminum that's in all the vaccines that a 6-month-old has had, so over that 6-month period, the amount of aluminum that's in the breast milk they would have drunk in that period is greater than what's in the vaccines. And if they're formula fed, it's 10 times greater. So the aluminum that's in vaccines is really very, very small compared to what's in everybody's diet. And it's not injected in your bloodstream. That's a myth. They don't go into your bloodstream. It's basically, although there's none even in the Pfizer vaccine, in general, aluminum is there as a good thing, because it increases the immune response.
Let me, and around, I'm sorry, I'm not trying to dominate. I'm trying to go in a certain here, because I've gotten so much, so many questions pertaining to this show. So, Nick, we talked way back when, and I'm going to ask you to refresh our audience and refresh my memory. You do have formal training, and you have a strong understanding of homeopathy and holistic treatments. Is that correct?
Not homeopathy, but more essential oils.
Okay.
Essential oils and massage therapy. I'm a qualified massage therapist. In my
so the question I got, and maybe you're the wrong guy, but I'm getting a lot of people asking me, can't we use homeopathic remedies to treat COVID? Or is there a homeopathic component to these vaccines?
The trouble with homeopathy is there isn't any real evidence that it works, and the science behind it just doesn't make sense in terms of the memory of water and things like that. Whenever homeopathy's been tested, it hasn't worked. So it's not that people don't necessarily feel better when they use it or get some benefit from it, but that's partly due to the placebo effect.
Right.
Half of the effect of morphine when treating severe pain is placebo. And yet morphine is a very effective pain med. No one takes that away from it. So, but in terms of COVID, there's nothing from the homeopathic side of things that's going to help.
Yeah. So, Ronnie, sorry, I kind of dominated there, but
I appreciate you asking that question. But I just wanted to clarify that you said absolutely there is no aluminum in the Pfizer vaccine.
None that I saw.
Okay.
I looked at the ingredient list yesterday and today, and kind of went through it, and there's no need for an adjuvant. They've actually got on record as saying, with specific reference to the UK incidents that happened yesterday. We'll talk about that later, but they were very confused as to what was going on there, because They said, we don't have an adjuvant, we don't have a preservative, we don't know what happened with these
Is it safe to say it's all natural ingredients, Nick, or am I out of line saying that?
Well, everything
natural, organic.
I think, yeah, it's one way of putting it, but I think the way that they are constructed, like for instance, the mRNA is produced in the lab. So we all make mRNA. mRNA is a naturally occurring thing, but that mRNA has been engineered in the lab. Okay, so yes, they're natural in the sense that they are chemicals that you might find in an organism, but the way they've been put together and the way they've been engineered in a way, that's a man-made construct. But there's nothing that is, even though some of the lipids actually have fairly complicated chemical formulas associated with them, we've used some of those chemicals in everyday things like laxatives or other pharmaceuticals. So there's nothing that's completely new for humans except for the idea of using mRNA as a vaccine. That's been studied and been investigated, but this is the first mass rollout of this technology.
So there are so many questions to ask, but you were kind enough you actually put together a presentation. Can we roll into the presentation and then back to the Q&A? Ronnie, is that okay with you? Oh, I think Ronnie can't hear me. Ronnie, can you hear me?
I hear you now. Yep.
Okay, we're going to roll into the presentation. Is that okay with you? Oh, I think Ronnie's having trouble hearing me.
No, I can hear you.
Okay. All right. So Nick, you put together some slides for us, including, and I'm excited because I actually had one of these slides ready to go that I'd gotten from another source, and then you provided it. And you know the slide because it's all over Facebook. And the good news is it's a truthful, A, it's true, it's not fake, and B, it's very positive in terms of showing the results of the vaccine, the early vaccine use data. So let's start. I've got page 1 here.
I wanted to put this up, and actually the reason why I was able to put this slide set together in short order is because I did a presentation for a company recently on COVID, and this was part of it. So I actually just, commandeered my slides. So this is critical, and this is a global view, but it shows two things that are in stark horror, really. One is that if you go back to March and April, we thought this was going to be our peak, and in fact, in Connecticut, it was our first peak. But as you see, even as we were winning, the rest of the world and even the rest of the United States was not. And what we really saw was kind of a flattening of the curve as people tried to lock down and tried to stay home. And yeah, we flattened the curve because there should have been an exponential growth and it wasn't. But then you'll see through the summer, there's spread across the world and outbreaks within the United States and elsewhere that have all contributed to a second wave. And now in the fall and the winter, we are now seeing a third wave. And these are daily cases. And we now have a total of 65 million. So we are nowhere near peaking. Now, it's possible that what we've seen in the last month is our third peak, and we may be heading down again. We can't say that. Maybe heading back up, or it may be leveling off. But either way, this is clearly not going away. And the social distancing efforts that everyone is desperately trying to do, which do work, because if they didn't work, this curve would be 1,000 times worse, they're not enough to get rid of this virus. I think that was the hope. It worked for SARS-1 back in 2002, because SARS-1 was, although it was much more dangerous than COVID, which is SARS-2, it was not as transmissible. And so you could very easily isolate people who had SARS, the first SARS, and it stopped spreading. And that hasn't worked for COVID. It is much more easily transmitted than we first thought, and it transmits when you're not symptomatic, which makes an absolute mess of things. So this is why we are where we are.
So when vaccines start to flood into the population, people taking them, it's going to reflect on this chart
like a huge difference. So to put it into context, when you don't have any control at all, about 2.5 to 3 people are infected for every 1 case. That's an average. And when you do the math in terms of how quickly that changes numbers, and we saw this in Connecticut because I tracked it, you will increase your numbers by 30% every single day, day on day on day. And that is true exponential growth. And that's what happened. We were growing at 30% per day until lockdown kicked in about 2 weeks into lockdown. And then after that, it started to slow down, and then the numbers went down. So exponential growth is based on 2.5 to 3 people getting infected for every case. Now, when you see that there's no growth, that means you're down to 1 person getting infected for every 1 case. That's 1 to 1. And we want.
That's kind of where we are now. Is that fair? We've been averaging 2,000 now for about a month.
Right.
Is that a fair statement for Connecticut, or am I getting ahead of myself?
I'd have to go back and chase the numbers for Connecticut because I haven't looked in the last week.
Okay.
But I can do it now, actually. Really bad. The fact is, though, that we need to get that transmission number, the R number, down below 1.
Right.
And the best way to do it is to bear that in mind as we go through the slides. So next slide. I wanted to make this point because it was actually in a review paper that I looked at, but I dug up some historical data too. This is the case fatality rate. So it's not deaths per population, it's deaths per case, per 1,000 cases. And you can see that the younger you are, the more likely you are to survive. We know that. But the older you are, that case fatality rate goes through the roof, and up to like a 30% mortality for people older than 85. That's 300 per 1,000 cases. That's a 30% mortality, and that's in the range where the original SARS was. And for whatever reason we don't fully understand yet, the younger you are, the better you do with SARS-CoV-2, which is COVID-19. Now, when people say it's no worse than the flu, or it's less bad than, that's clearly totally incorrect. So at the bottom, you see a pandemic influenza mortality. This was based on the worst case scenarios historically, looking at pandemic influenza. So not seasonal influenza, but pandemic, which is worst case, where no one has any immunity and no vaccine works. And that's around 5 per 1,000. So the worst case flu is around 5 per 1,000.
Right.
And at my age, I'm hitting 8.6. I don't want COVID. And I think this kind of highlights how dangerous COVID-19 is compared to the flu. And I think, honestly, people taking this not seriously enough is why we're in the situation we are. There's very much a reactive response instead of a proactive response.
Well, I mean, Nick, but it's funny because there's something floating around on the internet now, and it's accurate. The premise is wrong, but the numbers are accurate, and that is the overall U.S. death rate for 2020 is not all that much higher, tracking than 2019, 18, 17, and they give all the numbers. But what's not considered in there is it's all the people 65 and over who are dying, number one. And number two, they're not looking at all. They're not understanding that I had, you and I talked, I had it. The damage, I have not fully recovered in terms of stamina. The damage to lungs and heart from this is serious. And going, 10 years from now, I think we're going to see a lot of heart and lung transplant patients. Is that an accurate statement?
You're totally accurate on that last point. I'm not sure about transplants, but we are going to see significant problems with our workforce. I have one friend who was hospitalized. She's a healthcare provider who caught it, and she basically live blogged her COVID case and then went to the ER and then disappeared. And we didn't know what the hell had happened, and it scared us all. She apparently wrote goodbye letters to her kids because she thought that was the end. And she did pull through, but she recently updated us and said, she's back and she's alive and she got through, she's back at work, but she says she is not normal. Her lungs are taking a hit, her energy levels have gone, and people are also talking about mental health issues and problems of cognition and memory. There's something about this virus.
Where I feel it. I don't feel as sharp as I did before.
Yeah. Now, the other thing about mortality is simply not true. We have tens of thousands of excess deaths reported this year, in addition to the COVID deaths, which are in addition to the normal
deaths. Okay.
And in Connecticut in particular, at the peak, we were seeing 200 deaths a day.
Right.
Now, on average, an average day in Connecticut sees 85 people die.
Right.
and those are hard statistics. You can't fudge a death. You're either dead or you're not.
Right.
So when you have days where 200 people a day are dying of one disease, when normally you'd have 85 from every single thing combined, heart attacks, stroke, cancer, car accidents, everything, 85, and you're getting 200 a day, that's bad. I'm looking at the cases now in Connecticut. It looks like the 7-day moving average is sitting around, as you said, around 2,000, 2,500. And the deaths are creeping up too.
Yep.
So not as bad as they were
Right.
back in March. And honestly, that reflects the fact that the healthcare system knows how to handle this virus, I think. We're doing a lot better with how we're treating it. Talk about the vaccines. So I'm lumping together the two mRNA vaccines. Now, since I made these slides initially, we've got more data on Pfizer, so I'm going to focus on that in a little bit. The mRNA spike protein vaccines were both reported to have more than 95% effective, and we'll show what that means in a little bit. These was in very, very, very large studies. I cannot overstate how amazingly large these studies are and how fast they were recruited. In a normal vaccine study, and I've done quite a few vaccine studies, I've been part of national and global vaccine studies, you may recruit several hundred to several thousand people over 1 to 2 years. And between these two companies, just these two companies, they recruited 73,000 people over around 6 months. That's insane.
Thank
That is
goodness.
a huge amount of data. So it's not just that these companies were able to approve the vaccine quickly. They did it because they've got this data in 6 months instead of a couple of years, and it's due to this incredibly rapid recruitment. And I'm one of these people. I signed up for the Pfizer study, and many of my healthcare colleagues did. We were in these vaccine studies because we believe the technology is good, it's safe, it's potentially effective, and we want to do our part to move these things forward. Now, the downsides of both of these vaccines, and the Pfizer one in particular, is that they have very stringent cold storage requirements, -70, -80 degrees Celsius, so dry ice temperature, incredibly cold. And Pfizer has a distribution network that they've set up. And it's been done before. One of the Ebola vaccines is very, very cold as well. It's -60, -70. And it's been done across the world. But this is a significant issue. And Pfizer also, the formulation they're asking for approval is a 5-dose vial. And so it's not something you're going to be able to walk into a CVS and ask for, because they're going to have people lined up ahead of time, have a minimum of like 5 so you don't waste the dose. You're going to have to defrost it 30 minutes ahead of time at room temperature. It is not a simple administration. Now, the other one that
can I just ask you real quick, why does it need to be kept in such cold temperatures?
It's due to that mRNA stability issue. -70 is a standard temperature for storing mRNA. Even at -20, you'll start to see some degradation. So I think what both companies are working to do, and Moderna say they've solved some of these problems, and Pfizer says they're going to, is they're able to stabilize the mRNA in a way that it doesn't necessarily need that extreme cold. But -70 is a standard temperature for RNA storage. It just is. Even physicians are astonished at that, but those of us who've worked in the lab with mRNA, as I have, know that it's a real bugger to keep stable, and you have to keep it extremely cold.
That's why that Oxford medicine is so interesting.
Right. So I was initially very excited about this Oxford one, partly because obviously it's UK-based. It's a different technology. It's based on a chimpanzee adenovirus vector. So it also has the gene, it has the mRNA inside the virus vector. And the chimpanzee adenovirus is designed and engineered so that it doesn't grow in human cells, but it'll still deliver the spike protein gene. So in effect, instead of using this lipid particle that the other vaccines use, it uses the little adenovirus vector to get in there. Now, why on earth would they choose this? Well, they've been developing this technology for years. They had a SARS vaccine, and they had a MERS vaccine, which is the Middle Eastern Respiratory Syndrome virus, and they're both coronaviruses. So a new coronavirus shows up, and they're like, we'll just throw COVID-19 in there and see if it works. And it did. So the beautiful thing about the Oxford vaccine is they have a ton of safety data based on this adenovirus vector they've been working on for, since SARS, which is 2002.
Right.
So this is not, again, it's not a brand new vaccine. It's just a new use of an old vaccine that no one's heard about. Now, the interesting thing about the Oxford vaccine is they initially reported a 70% efficacy, but they had a smaller subset of people who received a half dose and then a full dose. And that modified dosing regimen was 90% protective. Now, the trouble is that subset was not as well randomized as the overall group.
Right.
And the numbers, just in terms of cases, aren't as high. So
in the U.S., they're continuing their trials here in the U.S.
Exactly. They're having to extend that study to get the numbers up and really make their point. So now
let me ask you this. Let me interrupt you and ask you this. If I wanted to sign up, or if one of our viewers wants to sign up for that Oxford AstraZeneca trial, how would they go about doing that?
There is a website called clinicaltrials.gov, which is the government website. All research, all clinical trials involving people must, by law, be registered on clinicaltrials.gov. And you should be able to search by company and by vaccine and by disease. People do this all the time for rare diseases for themselves. And you can look up sites which may be locally to you, and they'll have a contact name and a contact number for those study sites. My Pfizer vaccine was actually through a Facebook ad. It said, click here if you want to be in a COVID study. And I was like, all right. So that's how I got through a Facebook ad. But the clinicaltrials.gov is the place to go for any clinical trial you may want to be involved with. Now, the thing is, at this stage of the game, they probably have closed out their main study, but as you said, John, they're looking to extend it.
Yep.
And I don't know what sites are open in the United States. Most of the study sites that I was aware of with this vaccine were in Europe and in Brazil. And again, tens of thousands of participants.
Right.
The advantage is easier storage, it's refrigerated, it's much cheaper. AstraZeneca is committed to providing it at cost to countries that need it, and that's huge. Can you go back one bit, John?
Yep, sorry. Yep.
Because just today, one of the Chinese vaccines called Sinopharm was reported as being 86% effective. Now, this is weird because it didn't come out of China. It was data that was released by the United Arab Emirates. And the Chinese have already immunized 1 million people before they had efficacy data. They were kind of taken to task for that because it's not official numbers. We don't know a lot about the vaccine. So, but those are numbers that came out just today. And I want to focus on that efficacy rate. Remember I said you need 70% protection to shut down spread for COVID-19? If you've got a 95% effective vaccine, you don't need to immunize everybody. You need to immunize maybe 70% of the population, and you will get that vaccine, virus spread shut down. If you have a vaccine that is only 70% effective, you've got to immunize everybody to get the same level of protection. So that's why these mRNA vaccines are so exciting, because they're working even better than we expected. I think.
Will this virus be as eradicated as, say, smallpox 10 years?
I don't think so. I think what we're going to find is that we will get some herd immunity, and then we'll have sporadic outbreaks, and the virus may end up mutating in such a way that it's no longer a problem after a while. But we don't know. There are 4 existing human coronaviruses that circulate amongst people, very high level of circulation. 95% of the population has had one of these viruses at some point by the time they're an adult. But COVID-19 obviously makes people a lot sicker than these other coronaviruses, and so for now we need a vaccine for it. So yeah, this has been my beautiful slide that I've been posting on.
Slide everyone's talking about. Yep.
And this is taken directly from the FDA submission, and it's a cumulative incidence curve. So in red, what you see are cases of COVID appearing in the placebo group. In the blue, you see cases of COVID appearing in the vaccinated group. And I think the graph just speaks for itself.
It does. Yeah.
This is what 95% protection looks like, all right? You're 95% less likely to get the virus. It doesn't mean that 5% of you will get it and 95% of you won't. That's not what vaccine efficacy means. What it means is you are 95% less likely, even taking into account all the other things you're doing to minimize your risk, like masking and distancing and all the rest of it. And this is fantastic data. You'll also see that for the first 2 weeks, the graphs are pretty much the same. And that's because it takes about 2 weeks to develop an immune response.
Yep.
So this is beautiful because it not only demonstrates the vaccines work, it demonstrates that your body is working as normally as it should be. Human beings are predictable. So this is great.
And that shows it shows there at the point where the lines diverge.
Mm-hmm.
That's just after the first dose, right? Because I saw this,
right.
this
so
slide this morning.
Was given at time 0. And then at around 2 weeks in, your body's making the first immune response to the vaccine. It's been working for 2 weeks. And then finally, your B cells are churning out antibodies and your T cells are maturing. And at that point, you have some protection. And in this study, there was a second dose given at day 21. And in the Moderna study, the second dose was given around day 28. So both of these vaccines are currently a 2-dose series, but there's a strong suggestion here that the first dose gave you some protection.
Enough. Yeah, if enough people do it, that's the key. So when will we know how long these vaccinations will last?
So I don't have data to hand on the Pfizer one, but they're very similar, the two vaccines. And the Moderna one published very recently in New England Journal that they demonstrated strong and protective responses. And that's key, because we have to remember that antibodies don't always mean you're protected. The best example of this is HIV. People with HIV have very high antibodies against the virus, but the virus is still replicating and doing its thing. Now, for COVID-19, in the study, they actually had 1,000 people who were in the study who had positive antibodies. And there was still protection between those two groups who did not get the vaccine. There were 7 cases of COVID in the pre-infected group who got placebo, and 1 case in the pre-infected group who got vaccine. So it demonstrates that the antibodies we get from natural infection are not necessarily protective. So the Moderna results that were published, they showed that they had protective, strong responses at least 4 months out. And at 4 months out, the concentration of antibody was 10 times greater than from natural infection in previous reports at 1 month. That's huge, because normally you lose antibodies over time, and at 1 month, they're at the maximum you're going to get. So 4 months out, Moderna is demonstrating 10 times better responses than natural infection at 1 month. And I think we can expect the same from the Pfizer study. All the vaccine companies are very focused on the immune responses. They're measuring antibodies and they're measuring T cells.
And Nick, I just a heads up, we're good, but I got a text from TV. We're going to lose TV in about 10 minutes. So let's go through these frequently asked questions, and we've got a list of questions.
Yeah. One thing I want to go back on, there's a question mark on that bottom of that last slide.
Sorry, we'll go back. Yep.
Is the allergy concern. So yesterday, the UK rolled out a mass immunization program. As Ronnie said, the second person who got it was William Shakespeare. And but 2 people developed anaphylaxis or anaphylactic-like reactions to this vaccine and needed EpiPens. Now, when you actually read the story, you realize that these people had EpiPens on them. They were people with a history of severe anaphylaxis who, for some reason, reacted to the vaccine. And we don't know why, because, as I said at the beginning of this whole presentation, the ingredient list is not that impressive. There's nothing in there that they should have reacted to. It's very confusing, and it's forced the UK to issue a warning that if you have a history of severe anaphylaxis, you should not get this Pfizer COVID vaccine. I don't know how that's going to apply to the US, but that is, a concern. You don't expect to have people do that on 1 dose. Normally, when you're allergic to something, you are exposed to it, you develop an allergy to it, and then you react. So to get a reaction to the first dose means that these guys are pre-sensitized to something, and we don't know what it is.
Okay.
Because there's nothing in the vaccine that should do that.
Right. Right.
So we're missing something, basically.
Gotcha.
I put a few questions up that have come up on the physician groups, but also on some of the regular Facebook groups that I'm frequenting. Some people have worried that you get the vaccine, your immune system's primed, and then you get infected and your immune system goes crazy. And this is because a lot of the severe disease from COVID is due to inflammation. There's absolutely no evidence that that's been happening. It's very reassuring. They demonstrated this in the vaccines before going into human studies, actually, and now subsequently in the clinical trials. Even amongst those who were seropositive, there was no antibody-dependent enhancement. This is great. Very reassuring. Equally, there's no evidence that this is going to make autoimmune disease worse. Several people, hundreds of people, I think, with autoimmune diseases were in the study. No one had significant flares. There was a lot of myth going around early on about the vaccine is mRNA, it'll alter your DNA. That's impossible. mRNA does not alter DNA. Certainly not the way these vaccines are set up. DNA is used as a copying template to make mRNA, but mRNA doesn't go back. It's basically degraded once it's been used. So that doesn't happen. There's a meme that I saw, which is actually quite a convoluted, complex meme. It's quite clever, talking about infertility and the fact that there's a spike protein in the placenta called syncytin-1. Well, there is a protein in the placenta called syncytin-1, but it has nothing to do with coronavirus. It's actually more closely related to HIV, if anything else. It's a very, 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 very old protein that we inherited from some virus back in the midst of time that allows humans to make placentas. Go figure. Anyway, there was going to be no reaction to that protein. If there was going to be a reaction to that protein, women with HIV could not get pregnant, and they very clearly have successful pregnancies. Vaccine mandates.
Yeah, that's the big one right there.
Yeah, so legally, and this has gone all the way to the Supreme Court with smallpox in 1905, Jacobson versus Massachusetts, you can mandate vaccinations, and you can mandate enforcement and fines. And that's legal because in the setting of a public health emergency, your individual rights to be a fool can be trumped, for want of a better word. And you can enforce public safety measures that go against normal rights, okay, because it's a public health emergency. Now, here's the caveat to all of that. COVID is not smallpox. It is not as fatal as smallpox. The vaccination does not have to be as widespread as we needed to control smallpox. Smallpox virus is incredibly stable and persists for years in the environment. COVID does not. So my hope is that this just isn't going to happen at a society level. You won't have to, because people are going to hopefully be sensible, and most of us will get immunized to the point that there'll be sufficient herd immunity that it'll become a moot point. But can people legally do it? Oh yes, they can, and the Supreme Court has said they can. So
that's important because we had Governor Lamont on a couple of weeks ago, and we asked him the same question: "Is are you going to mandate?" He said he acknowledged it's a tough question and didn't.
You won't have to, I think. But can people do it? They can. And of course, as a company, you may have to.
There was something from Harvard, and shame on me, I should have it here, but I don't. Where I think they're going to mandate, and I know it created a little bit of a kerfluffle.
Yeah. Now, if you're a private institution or if you're a company or a country, there are countries who mandate yellow fever vaccine, and you can't come into their country unless you have yellow fever vaccine. They may be able to do that, and that's outside of our jurisdiction. So, food for thought. Safe in pregnancy, we don't actually know that. It should be. This is only an mRNA vaccine, but people who entered the study were advised to practice contraception, male and female, and you couldn't be enrolled if you're pregnant or breastfeeding. Having said that, a very small number, I think 20 something, 23, 24 people, women, not men, women got pregnant, and they are being followed. They do not have all the outcomes because the data is scary. Pfizer reported that in the placebo group, there was one miscarriage, but there wasn't any miscarriages in the vaccinated group. That's all the data we have. That's basically it until we know more. And so when you get, again, talking about mandates, probably shouldn't mandate pregnant women to get it.
So on the topic of mandates, this is one of the topics, Nick, we got so many questions in advance as well. So for those that have received the vaccine, how do they prove it? Is there going to be a program for somebody who's gotten the vaccine when they travel to another state,
X on your forehead,
airplane, that sort of thing? Well, I don't want a kid because I think of Germany in 1942. But how do we prove that we have gotten the vaccine, that we followed the advice and gotten?
So maybe the same way as yellow fever. There's actually a little yellow card you get that you carry with you, and it's stamped by an immunization center, and only the centers can provide the cards and the stamps.
Okay. I think that's important. What now? John Geckler asked, what are the possible long-term risks, any chance of developing myocarditis from this vaccine?
I would say that's next to zero because there's nothing in the vaccine that could do that. But there's definitely myocarditis from the virus. The virus is a lot more complicated than the vaccine. It has 3 open reading frames, each of which can be used to make multiple genes, whereas the vaccine has 1 gene, which is on the outside of the virus. The virus itself does damage the heart. We've known that from the very beginning with just, tragic stories of people surviving COVID and getting through the lung disease and then leaving the hospital and dropping dead of an arrhythmia. And the staff are like, what the hell? What it is? But that's been happening. And
right.
So the virus itself definitely does that. The vaccine has no evidence that it's caused any problems at all. This vaccine, at least, the mRNA vaccine.
Looking at a couple of questions from Rocky Holland. Is there evidence that middle schoolers and high schoolers are major sources of transmission? What would you do if you were the boss for a day? Would you transition to full-time in school, full-time remote, or go with a hybrid program?
It really depends on the school. Okay. Now we know from Israel, which had really good data when they opened up. Israel initially opened up junior grades only, very small group numbers, like 1, 2, 3 grades, kindergarten 1, 2, 3, and very small class sizes, restrictions, whatever, masking, isolations. Nothing happened. Great. So they went full open with no restrictions. And a month later, the country is on its knees trying to deal with these COVID cases because they did it wrong.
Right.
Now, my own kids, I want to say, are currently, after having been locked down for 6 months, they're currently in bricks and mortar school. But it's because the school has built little cubicles, plastic cubicles between the desks. The kids are masked, they're temp checked on the way in. They have questionnaires about, are you having these symptoms and all the rest of it. So they're doing, and they're cohorting for lunches, they're doing a lot. And I was in contact with the teachers early on as we were doing distance learning, and they felt very reassured and very confident that their school was doing everything that they could do to keep the kids safe. So I felt confident that for my kids in that school, they were okay to go back. Now, that's not going to be the same everywhere. It is such an individual discussion. And you have to also balance it with, are you yourself or someone in your household at risk? You don't want to have an elderly person living with you if your kid is going to get COVID and bring it home. Kids, on the whole, it's all with the CDC charts, kids generally do very well. Not a zero risk, but they generally do so much better. But if you have a high-risk person at home, your personal comfort level is just not going to be there for that. And that's fine. I think the important thing with the schools is help the schools offer options. Don't force them to open, don't force them to stay closed, unless there's an actual catastrophic outbreak in the community, and that's the only thing you want to do is lock down. But give people options and help people do that. It's very, very, very difficult to do this. The teachers are working incredibly hard, as are the parents,
right,
and the kids.
Yep.
I mean, my kids did all right, and they kept their grades up. But for some people, it's just been disaster.
And
here in West Hartford, we've kept the schools open since this fall, and until yesterday, actually, there had not been any schools that had to close. And then they had a situation at one elementary school where the contact tracing didn't clearly indicate a cause. They haven't said that it's a spread in the school, but they can't rule it out. So they've paused it and moved to virtual learning for a couple of days to try to get that under control. But otherwise, it's looking like the spread really is not in the schools, even though we don't have those plexiglass cubes here in West Hartford. We have mandatory masking and cohorting and distancing to the extent that it can be.
Yeah.
So there were two other questions from Rocky, but I think we really covered them. Just one about a percentage of population needing to get vaccinated, and talking a little bit about social distancing. So I think we really covered it, Rocky. Hopefully you're okay with that. Nick, we got to wrap up. We're losing TV here. So I'm really grateful. Thank you for reaching out
no problem.
audience. Nick has moved on, both physically and with his career. So we hadn't been burdening him, but we're very, very lucky. He reached out today or yesterday and is still offering his expertise to us. And Nick, Ronnie and I are both grateful for that. Thank you very much.
No problem. Anytime.
We look forward to visiting with you again as this continues. Who would have thought when we had that session in person back in March that we'd be sitting here, 9 months later.
The mic back and forth from, remember that? Pass the microphone. So
I think we're almost exactly 9 months later, actually. Almost to the day.
Yeah. It was March 11th, I think, right? Or March 10th. So, yeah. So anyway, for Ronnie Newton and Dr. Nick Bennett, I'm John Lyons, and we don't have another show scheduled this year, I don't think, Ronnie. I think it's going to be the new year before we do another show. Is that right? Or do we have another show this year?
Not as far as I know.
Not at this time. So if we don't, happy holidays to everybody, happy New Year to everybody, and we'll see you in January.
All right.